Hello and welcome. I'm your host, Jill Stokeld, and this discussion is being brought to you by the Hematology Oncology Clinic, a partner practice of the American Oncology Network. We are honored to be joined today by one of their leading physicians, Dr. Michael Castine. Dr. Castine's work is at the forefront of cancer treatment, and today our conversation will focus on a topic that impacts countless men and their families: prostate cancer. We'll discuss everything from the critical importance of early detection, promising new treatments, and the unique supportive approach Dr. Castine and his team provide for their patients right here in our community. Dr. Castine, thank you for making the time to be here with us today.
It's my pleasure to be here, Jill. Thanks for having me.
All right. You ready to get started?
Sure.
Okay. So can you share a bit with us about what inspired you to specialize in oncology and hematology and how your path led you to where you are today?
Sure. So the story that I usually tell is the one that dates back to my childhood, and my mother was the only nurse in the family. She was one of four, but her mother was one of 13. And so there were quite a bit of illness that ran through the family as they aged, her aunts and uncles and cousins. And back then there was no home health or hospice. And my mom got the call on many occasions, and she was the one to answer the call, whether it be to go and be present for them or them to come to our house. One of her very, very close cousins, who was like a second mother to me, and her son and I were the best of friends. Well, she died in her early 40s of lung cancer. And I think I was about 10 or 11 years old, and I can remember the morning my mom came in and sat on my bed and said, "Hey, your Aunt Lucille died." And I just remember how heartbroken I was about that. And my cousin moved away, so I didn't get to see him very much anymore. All of that said, those were some of the driving factors that led me here. A love of science helped. Chemistry teacher in high school was very sort of instrumental in that. And then, aside from that, I think it was my faith and the things that my parents instilled in me about serving others. And
right.
So, yep.
You were kind of modeling your mom, who was a caregiver.
Yes.
Absolutely.
Yes.
Okay. As someone who treats a wide range of cancers, what role does prostate cancer play in your practice today?
So prostate cancer is one of the most common malignancies. Breast, colon, lung, and prostate are probably the four most common. So it is a very common disease. And what makes it even more common, really, in any general oncologist practice is the number of men who contract the disease, but also how long they live. So they do tend to have a fairly long track record over the course of their disease. And so, if you've been in practice for a while, you'll accumulate prostate cancer patients. So in my practice, after 25 years or so, I have people at all stages of the game, people who are referred very early on, maybe who don't even need my help, but need consultation or advice, to the people who have run their course and maybe they're in the phase of palliative care and comfort measures at this point. So we do see the spread of them over the practice.
Right. So what should men and their family know about early detection?
So in most cancers, we feel that early detection is one of the keys to cure. If we can detect a cancer early enough, we feel like maybe we can either contain it or we can remove it, and that provides the patient disease-free time. And the hope is that that time turns into extended time and eventually cure when you don't see any relapse. So early detection is important in that. Prostate cancer is a little different in that there's been a lot of contention amongst experts and arguments about, does early screening really lead to increased survival or not? But I would say that most men should be screened, and especially those men who might be at higher risk really need to take it into consideration and take it to heart. And those would be people with family histories, especially primary relatives or relatives within 1 or 2 degrees that have had prostate cancer in their family. That increases their risk. So the average man has about maybe a 1 in 6 risk over the course of their life, and it raises to about 1 in 3 if they have a family member. So the screening's important for them.
Absolutely. And about what age should the screening? I mean, I know it varies obviously based on that. But
Right, it varies. I would say most of the guidelines are probably going to say around the age of 50 or so is probably the latest it should start, unless you have a close family member who might have been diagnosed young. Then our general rule of thumb is, hey, that person's age, take 10 years off, and that's when you should start. That's just a general rule. But if there's risk, the higher the risk, probably the earlier it should start. We are seeing younger people diagnosed with many types of cancer now, and people are trying to figure that one out.
right.
Yep.
Are there certain symptoms or risk factors that are often overlooked?
So I think the biggest risk factor is probably the family history. But the biggest risk factor for all of us with any cancer is age. We're all susceptible to it as humans. And so as you get older, the screening becomes more important. However, with prostate cancer, we'll talk a little bit about expectant observation or surveillance that's actually offered to some men with prostate cancer. But that said, probably the biggest risk factor of prostate cancer is family history and age. Yeah.
Okay. So, from your experience, what kind of advancements have you seen in treatments and, what's new in the world of treating prostate cancer today?
Yeah. So all the way down to screening, probably the biggest advancement has been the laboratory phase of it, where the PSA has become ultra sensitive in a way. That test has been refined over the years that I've been in practice, and it's a very good test to detect prostate cancer, and it's a good early step, but still there should be an exam done. From when I started, there weren't very many treatments for prostate cancer. As a matter of fact, the urologist would often treat it. The one drug they would use was probably the key drug that was out there. It was a hormone blockade drug called Lupron, and it was used extensively to control early prostate cancer, and and I say early metastatic prostate cancer, and it worked well for most men. It would work for years. We had some add-ons to that, but ultimately, when I trained, there was one chemotherapy drug that was given to people, and it was often very late in the game. They were often extremely tired and beat up from having hormone deprivation for years. Occasionally we would give it. It was around that time that a different chemo started to emerge as, hey, this may actually be effective in prostate cancer. Still, it was very primitive. Over the course of 25 years, there were drugs that were developed to use your immune system against prostate cancer, and that was one of the early developments of almost like vaccination type of therapy that would be done, where cells were harvested and trained against the prostate cancer and then put back into men. We've advanced in chemotherapy drugs now. We've advanced in targeted agents now for certain men who might harbor mutations in their prostate cancer that cause DNA dish repair mechanisms, and these targeted drugs may be effective for them. We've developed new hormone blocking agents in addition to the Lupron. So the Lupron is still, believe it or not, is still a backbone of many things that we do. Many of those targeted drugs now are extremely effective and can extend the effectiveness of Lupron, sometimes even for several years. And so we've gotten better about managing it at different phases of the game. However, we still can't cure it once it's metastatic. That's still that game of management.
And what about the side effects of these new advancements and treatments?
Right. So the chemotherapy drug that we use now there's a couple of them. They're probably a little bit milder than what we used to use when we started. The targeted therapies do not carry some of the same toxicities of the ones we had before, although when you take away a man's testosterone in order to treat his prostate cancer, many men experience malaise and fatigue, muscle mass loss. We try to convince them to as much as they can be a gym rat, although most men are not going to do that, but we try to encourage them to stay active and actually try to exercise even if there's someone who won't. But those are the main downsides to it. There are some newer therapies as well. You see advertised a medicine called Pluvicto, which is now sort of a targeted radiation therapy. It's given intravenously, and it's a tagged radioactive particle that travels and sticks to PSA or membrane PSA on the prostate cancer cells itself and delivers the radiation directly there. There have been some radioactive things prior to that worked in the bones. So we've had some good advancements. Saw a gentleman yesterday actually, been a longtime patient of mine, and he's dealt with metastatic prostate cancer now probably for about 10 or 12 years.
I think that's kind of like one of the main things that I see. I can remember, early on in life when someone was diagnosed with cancer, it was kind of, especially if it had progressed and was metastatic,
Right.
But now people can live with cancer.
Correct. That's the paradigm that shifted in my lifetime. We've seen the death rates from cancer decrease a percentage point or two every year over the last 20 years. It really bumped up when immunotherapy came in, but I always tell the story to my patients when they ask me, hey, have you ever done this to someone before? When I pull out a new treatment or something that's just been FDA approved, and I'm like, well, no, you're the first. And they look at me and say, well, wait, what? And I said, well, there were 40 drugs when I started, and now there's over 1,200. And so, there's been a lot of advancement and research done and a lot of FDA approvals since I finished my fellowship. So, yeah.
That is amazing.
Yes.
But it's great because
That's
it
great.
means that they're, like, to your point, they're researching and working to get
Correct.
to get better treatment. So how does the Hematology Oncology Clinic approach treatment planning for the prostate cancer and the whole experience? Because it's really, I'm going to say, a family affair, but cancer, when someone is diagnosed with cancer, this, the entire family and their world around them is impacted.
Sure. So I would say probably the number one advantage that we have is we're relatively, at least here in Louisiana with my company, we're relatively a small, tight-knit operation in the two clinics that I have. And I would say that we're probably just an extension of the patient's family. So when people come in our doors, my staff know their name, they know my staff's name. I can hear them laughing and joking. I can give someone bad news and we talk. And even though we may talk about hope and how it's so important that hope is always held on to, that they'll leave the office and I can hear them laughing at the checkout. And so I think that their family provides them their love and support, and we try to be the closest extension of that we can be. And I think most of my patients feel that when they come in the door. So but there's a lot of counseling, there's a lot of talk, there's a lot of question answering, there's a lot of explanation. The more we educate, the better they do. And the reason for that probably is we set expectations and they know what to expect when I give them that prescription or I give them that treatment. And the hope is that, they'll do well with little or no toxicity, but setting the expectation gives them that comfort to know that they have a backup. Hey, I can call. I have plenty of experience. I have a nurse in my office who sits next to me who's been a nurse for over 50 years now. And she has a lot of experience. She's very personable. She takes good care of the patients. My grandmother used to look at me when I did something funny and say, God watches out for all his animals, even the dumb little ones. And
I like it.
I think God has put these people in my life because I'm still one of his dumb little animals. I wouldn't be what I was without my staff. They're wonderful and they treat the people like family.
I can sense your care and compassion for your patients, their families, and your staff, and I know that just envelops the people who come to you.
Yes, it does. I think so. Anyway, I hope so.
Yes. So, in addition to your clinical work, you've served as the past president of the Louisiana Oncology Society. What were some key priorities you worked to address during your tenure there?
Yeah, so most of our focus when I was with the Louisiana Oncology Society dealt with a lot of the changes that were going on in government. There were a lot of changes happening at the federal level. There were some at the state level. We worked amongst ourselves to try to preserve oncology care in Louisiana as best we can, negotiating with Blue Cross over time over things like pathways and trying to be involved in how that would look for them and trying to streamline things for them, but also make sure it was equitable for the patients, that they were getting the things they needed and the insurance wasn't heavy-handed, holding them back. And so there were advocacy attempts in that regard. We traveled to D.C. a few times to meet with leadership there, sat down with several people in their offices to explain things to them about chemotherapy, about how it works, about the expenses that are involved with it. Sometimes they get stuck on one thing, hey, we just see this thing, and then we see that this is charged. And I'm like, yeah, but nobody takes out my trash for free. And I have special trash that has to go to a special place, and it costs money, And so they began to understand that regulations do impact us. I think probably my key was the oral parity law. So oral drugs were becoming more and more common, and insurance companies were carving them out. So a patient might have a $20 copay for an antibiotic, but the insurance company would tell them they owed 20% for a $10,000 a month cancer drug, and nobody could afford $2,000 a month. So there were other states that had passed this type of law. I think it was Representative Cromer from Slidell. He championed it. We helped him with it. He drafted it. And then I went and testified House and Senate here in the state. And one of my patients was a representative at the time, and he came in the office one day shaking papers at me. You need to see this. I've never seen this before. And I said, well, what is that? He said, it passed and nobody voted against it. And I'm like, really?
Wow.
So we had a unanimous vote in the House, and I'm not sure if it was unanimous in the Senate or not, but it's pretty close. And so what that law did was said that as long as you weren't on a government program, you could get your cancer therapy no more than $100 a month out of your pocket. And still to this day, believe it or not, I'll send a prescription for a patient. They'll come back and have struggled with it, and I'll say, hey, there's a parity law.
Yes.
And we have to call and remind them.
We might need to send you to testify on some other things to get some things approved.
Be happy to try.
Oh, yes, yes.
I have been there for other things, but unfortunately, politics is a nasty little world, isn't it?
Yes.
So-
But I mean, that, to your point, like having access to the treatment, equitable access to the treatment.
And that's
is
what it was
so
all about.
Important.
Yeah, we were seeing people who were going without simply because of these copays. And again, the insurance companies were just carving these things out of the plan. And it was a hurdle that was unachievable.
Right.
So, yeah.
Right. Well, thank you.
No.
So looking ahead, how do you see the field of oncology, in particular with prostate cancer, in the next 5 to 10 years?
So I would think as an oncologist and as any patient with cancer would always hope is that, hey, we'll improve the cure rates. And I think that's really what we want to do. Unfortunately, most of the diseases, especially prostate cancer, it's fairly complex. We're learning more about it molecularly, and there are more targeted therapies that are being applied. I think we probably need to be a little bit better on the front side of it with regards to screening and maybe with regards to the techniques that we might employ for cure. Prostate cancer's kind of been held back, and I won't get into any detail about that, but there were some things that occurred in the 90s and early 2000s that maybe held back some of the research and things that were done. Now, most of those things have been cleared out of the way, and the research has really taken off. But I think for the advances we've seen in something like breast cancer and the cure rates we've seen there, where it hasn't been by miles, but maybe by inches. You know, we cure a lot of people with breast cancer, and we continue to, but it's only because we improve the recipes that we have now. In prostate cancer, I still think that is that recipe hasn't gelled yet, and the therapies I think are there. I think we just don't know the right combinations, and we may not be putting them in the right sequence or order. And I think that's what I mean. So when you talk about therapies that go into you, medication therapies, which what I apply, radiation therapy, surgery, when you think about those three modalities to try to cure cancer, I think we could probably be better, but there are some very smart people working on it, a lot smarter than me. And so I'm sure they have that in mind. And I'm sure the cure rate will get better. But we need more research, and we need men to do research. Women will, and breast cancer, you know, it's not hard to convince a woman to join a clinical trial or do something. Men are more private about things. Mm-hmm. That's been a big hurdle with prostate cancer. African American people, there's still hurdles to get them onto clinical trials, and we see that, and it's, you know, and for whatever reason, historical or whatever it may be, those things could improve. And I just think we need to do a better job of it. And I think we have as an oncology community in general. But the hope would be that we would cure more people. And it may be earlier detection. You know, maybe that's the way to do it. I don't know.
Right.
Yeah.
Well, the men need to join the trial so we can get the research to get going.
That's correct.
Do the women need to tell them to do this?
Probably so. Yeah, maybe so. If they're smart, they'll listen.
Yes, right. So finally, what advice do you typically give a patient and their family when they're facing a prostate cancer diagnosis?
Yeah, that's a great question. So it all depends on what stage they are when they come through the door. I think the most important thing I try to give to them is hope, whether they might be drastically ill or just somebody who's coming for a consultation because their PSA is high and a doctor told them they have prostate cancer. Even those who are drastically ill, my biggest thing is to try to alleviate fear. I think fear is just a horned little guy renting space in your head. And I think we all suffer from it. It's hard to run away from it, or hard to push it down where you can make rational decisions. So my role in it is really to try to alleviate their fears and then begin to speak rationally to them about what their options are. I have people have come to me and say, I'm not doing anything, and I saw just terribly ill people, widely metastatic cancer, and especially if it's prostate cancer, you may be able to offer them a pill and offer them an 80% chance of relief of their symptoms with almost no side effects. And so to sit down and try to convince somebody that the pill's not chemo, explain to them how it works, show them on paper, hey, look, these are the side effects that the FDA made them write down. These are not bad side effects, and we're going to watch for this one and that one, and here's what we're going to do. Most people will sort of push that fear down and actually maybe make a try at it. Now, there's this big thing about whether we should push people to palliative care or treat them, and I'll tell you, I'm a person who's going to offer treatment, and I won't hesitate to talk to them about death and dying and mortality and those types of issues, but I still think that we have to have the hope that if there's treatment and people can feel better and take treatment without much toxicity, we at least need to offer it to them, and they at least need to consider trying it. If they decide to stop it, so be it. Most of the time, the side effects we have nowadays remit very quickly if they're there, and stopping it usually puts them back to where they were before toxicities, but everyone should actually have their try at it. And I think that's the thing that we try to do in our office, is give them hope.
And education. Dr. Castine, thank you so much for your time
pleasure.
Today and sharing your wisdom with us and the viewers. So, your insights on the future of treatment and the importance of early detection, as we were talking about earlier, are so important. For our viewers, I would say the key message is that with today's medical advancements, that in a dedicated care team such as yourself and your staff, prostate cancer diagnosis can be managed and you can live with cancer, even if it's metastatic.
That's correct. That's
Thank
correct.
you.
Yep. You're
Thank
welcome.
you.
Thank you.
To learn more about Dr. Castine and his work, please check out hocbr.com. Again, that's hocbr.com. On behalf of the Hematology Oncology Clinic, I'm Jill Stokeld.